So good evening everybody from Rheumatology TV. We are live now. I am handing over to the renowned rheumatologist Dr. Ajit Nalawade.
Thank you, Rahul. Uh, Good evening, ladies and gentlemen, and it's my pleasure to welcome you all on behalf of Sancheti Hospital for this first session of the web series in rheumatology basics that we have planned. Today we have with us a very good speaker, Dr. Gayatri Ekbote. She'll enlighten us on the approach to patients coming to our clinics with multiple joint pains. And later on, we have Dr. Nilesh Jagtap and Dr. Nilesh Patil, who will be joining us for the panel discussion. Dr. Gayatri Ekbote is a rheumatologist. She has done DNB rheumatology from Delhi, Medanta Hospital, and just recently shifted to Pune. She was in Sassoon Hospital. Now she has been attached to Sancheti Institute as a consultant. Dr. Nilesh Jagtap, probably you all already know, he's a renowned orthopedician from Pune. He practices in South Pune, has his own hospital, and he will be guiding us on the orthopedic perspective and what practical issues they face in day-to-day practice. And Dr. Nilesh Patil, also a young rheumatologist attached with Sancheti Hospital. I welcome you all again. And just to uh, clear the context for today's talk, I would like to start with one experience I had yesterday. A patient with 3 years history of rheumatoid arthritis. Now, I saw her for the first time, and I I was ready to answer all her questions. And when I diagnosed rheumatoid arthritis and said that it's already established, you have deformities, and will need lifelong treatment, but some deformities I cannot reverse, and all those things. I was ready to take all the questions while counseling, but I was stumped with one question: that why so many doctors I have consulted have taken so much time to initiate disease modifying drugs, and why I have developed erosions despite I have been consulting various doctors for past 3 years. So I really couldn't answer, and the today's talk probably will help us to reduce that time, the the disease onset and initiation of appropriate disease modifying drugs. So even the research shows almost it takes 3 to 5 years for patients to be initiated on appropriate drugs under expert guidance for such conditions. I would like to invite Dr. Gayatri to take over from here and enlighten us about the approach to multiple joint pains.
Am I visible and audible, sir?
Yes, you may
Yeah.
proceed. Yeah.
Okay. Thank you, sir, for nice introduction. And first of all, I would like to thank again Dr. Parag Sancheti, sir, and Dr. Nalawade, sir, for this opportunity. And of course, Dr. Jagtap, sir, for agreeing kindly to moderate our session. And Nilesh, sir, of course, and Chaube, sir, too. So today, my topic is actually approach to multiple joint pains, but from rheumatological perspective, I think let's keep the topic to approach to arthritis because that is something we have to address. So I think last month we had a lovely session on approach to arthritis, or including the clinical features and management too. So just the few slides will be repetitions of the earlier, but after that I think we'll have a proper approach. So as I said, or as the definition or as the word says, arthritis is actually itis. It means joint inflammation. and it is this is used to describe almost 200 rheumatic diseases. So only rheumatoid arthritis and spondyloarthropathy or gout are not the only arthritis which we see in day-to-day practice. These could be benign conditions, where but there are more sinister or the dreadful conditions which need more attention, and just joints could be seen, but underlying disease could be severe. So I think the approach is quite easy, but when patient actually comes to us, as sir said, it's important to know when to start DMARD, when not to start DMARD, etc. So first of all, patients usually come to us with a lot of pain. So we have to know whether the pain is articular or non-articular. The disease duration or onset, is it acute, which is less than 6 weeks, or chronic, which is more than or equal to 6 weeks? Is it inflammatory or mechanical? So today's topic is arthritis, which is itis. So we'll mainly be focusing on inflammatory joint conditions. Then the one of the most important parts is pattern of joint involvement, which we all usually uh, find it little more difficult to know the pattern and to address the issue. And of course other associated symptoms, because this I have been taught, and almost I feel all the rheumatologists in the world probably would have been taught that rheumatologists are first and foremost, they are internists, they are general physicians first, than the joint specialists. So we have to address other associated symptoms ranging from constitutional symptom to other systemic involvement. So of course this is a joint. It's a simple diagram of joint, so showing synovial cavity, bursa, then synovium lining it, and then there is muscle, there is tendon, etc. And there are ligaments which there is a ligament which joins the muscle to the bone. So basically this constitutes an articular structure. So there is in articular structure consists of synovium, synovial fluid, articular cartilage, intra-articular ligaments, joint capsule, juxta-articular bones, etc. Whereas non-articular structures are tendons, bursae, the muscles, bones, nerve, skin, etc. When patients have articular pain, they have pain in both active and passive movements, whereas non-articular, they will have sorry. Whereas non-articular pain will be only on active motion and not in passive. Articular pain will have limited range of motion in both active and passive movements, whereas non-articular will have focal tenderness. Obviously there will be a swelling, deformity in articular pain or articular involvement, whereas in non-articular involvement, deformity, crepitus, instability will be rarely seen. So non-articular conditions, just to go to brush them up, they include shoulder joint conditions such as rotator cuff, frozen shoulder, subacromial bursitis, rotator cuff tendinitis. The elbow conditions include medial or lateral epicondylitis, olecranon bursitis. Wrist conditions include decurvence, tenosynovitis, trigger finger, dupuytren's. Knees, of course we have bursitis. Hip, obviously we have GT bursitis, iliopsoas bursitis, adductor tendinitis. In ankle we have ankle tendinosis, which is I think one of the commonest conditions with which patients present to us. Then we have calcaneal and retrocalcaneal bursitis. And in whole of the foot we have plantar fasciitis, hallux valgus, Morton's neuroma, etc. So this is just a list of non-articular conditions, and we get to see a lot of patients coming with these problems. Now, this is one of the most important things to identify whether it is inflammatory or non-inflammatory involvement. The usual pain of inflammatory arthritis is in the morning, because after the rest, patients usually have pain. Whereas non-inflammatory is PM, because it's a degenerative condition, and after a certain period of activity or after a certain period of exhaustion, they get pain. The inflammatory swelling, erythema, warm, aim, stiffness, they are prominent, and usually swelling arises from the soft tissue. Inflammatory joints may have systemic features. The inflammatory markers or leukocytosis will be present in the inflammatory conditions. Just give me 1 second. Sorry. Whereas Whereas there are certain infectious conditions which can also lead to inflammatory arthritis. There are other conditions like crystal arthropathy, immune-mediated diseases like SLE, vasculitis, reactive arthritis, etc. Non-inflammatory conditions are degenerative, osteoarthritis, overuse tendinitis, bursitis, trauma, neoplasms, fibromyalgia, etc. The most important part is history taking. We have to know disease duration, whether it is acute or chronic. As I said, acute is something which is less than 6 weeks. Then we have to understand the pattern of joint involvement, whether it is intermittent or continuous. We have to know aggravating and relieving factors, associated early morning stiffness, axial involvement, associated swelling noticed by patient, then drug history, of course, whether patient has any fever which is preceding or accompanying, whether patient has any seronegative features like loose stools, urinary tract involvement, skin involvement, or any IV drug abuse. Okay, so coming to the pattern of joint involvement, mono, as the name suggests, it's single joint involvement. When you have monoarticular or acute monoarthritis, we have to divide it into inflammatory conditions. The inflammatory conditions include infectious arthritis, gout, pseudogout, which is CPPD, or reactive arthritis. Usually, most of the times, knees or ankles are affected. Then there are certain conditions like bursitis or tendinitis. Non-articular conditions like trauma to that particular joint or fracture, or there is something called as reflex sympathetic dystrophy, can give rise to acute monoarticular involvement. Oligoarthritis means less than or equal to less than 4 joints, that is these are 2 to 3 joints usually, and monoarthritis. So inflammatory conditions of oligoarthritis include psoriatic arthritis, spondyloarthropathy. There are certain indolent infections like tuberculosis. Then in children or the people less than 16 years, we see postearticular or enthesitis related arthritis, which is juvenile inflammatory arthritis, and pseudogout. Whereas non-inflammatory conditions include osteoarthritis, osteonecrosis, which is also called as avascular necrosis. I think orthopedicians will be much more aware. Then there are certain joints which are Charcot joints or neuropathic arthritis. The conditions are diabetes, syphilis, etc. Then hemochromatosis and PVNS. The last two conditions are little rare and we usually don't see them as much as we see other conditions. So polyarthritis, chronic polyarthritis, of course, the degenerative chronic polyarthritis, which can include hand or knees, include osteoarthritis. And there are certain inflammatory chronic polyarthritis conditions. Rheumatoid arthritis being the prototype, it is a typical chronic symmetrical polyarthritis. Then there is an entity which is called as undifferentiated inflammatory arthritis. Then certain connective tissue diseases like SLE, dermatomyositis, etc. Then we have polyarticular juvenile arthritis. Then there is something called as Still's disease or adult onset Still's disease. It's not a good condition when patients have systemic features like fever, rash, or lymphadenopathy associated. When patient has monophasic disease, it's okay. But when patient has the flares of any of the features involved, then we have to pay much more attention. But it's very rare, and usually the patients come to general physicians because they have many systemic features. Little rare polyarthritis or acute onset polyarthritis which are less than 6 weeks. The non-inflammatory conditions include hemoglobinopathy like sickle cell. We usually see them in different areas in Maharashtra. Then amyloid, which is extremely rare. The inflammatory acute polyarthritis conditions, especially in post-COVID era, we are getting to see a lot of viral arthritis, then serum sickness or reactions or allergy to certain drugs. Then early onset CTD. Most of the times in our clinic, we see that SLE patients can have early synovitis or early onset CTD. Rheumatic fever, I think my generation people may not have seen as many rheumatic fever arthritis as probably earlier people or the senior physicians would have because of the because of penicillin use. But rheumatic fever, children definitely used to have acute onset polyarthritis and with associated with fever and sometimes with sore throat. And after that, after the examination, probably pediatrician or physician would find murmur and patient would be labeled as rheumatic factor depending on their raised CRP or ASO titer. Then there are two unheard conditions or unsung conditions by other specialties, which are palindromic rheumatism. This is one of the important types of intermittent arthritis. And there is one more condition which is known as RS3PE. The RS3PE means remitting symmetrical seronegative synovitis associated with pitting edema, and it is usually seen in elderly population, and it could be a form of to polymyalgia rheumatica or certain malignancies. So when elderly people come to us with symmetrical polyarthritis, and usually when rheumatoid factor is negative, and when they have a lot of edema, we have to do systemic examination very carefully. We have to look at other systems like lungs or other bony involvement. They may have underlying malignancy. So this particular condition, though very rare, but we have to pay attention to it. So this is just a pictorial presentation of what I just said. Uh, First CMC, this is the commonest joint involved in osteoarthritis, which is a type of degenerative arthropathy. Then many a times to orthopedicians and also to rheumatologists, we see decurvent stenosynovitis. This is usually after trauma or certain infections. So as I said, pattern of joint involvement is very important. The wrist involvement is usually seen in rheumatoid arthritis, pseudogout or CPPD arthritis. They may have certain underlying comorbidities like diabetes, thyroid disorders or parathyroid disorders. They may have gonococcal arthritis. So the proper history in sexually active males and females is very important. It is usually acute in nature, and they may have some pustular skin rash. Then juvenile arthritis, especially systemic juvenile arthritis, will have wrist involvement along with deformity, and this all can lead to carpal tunnel syndrome. So most of the times to orthopedicians or to us, patients actually come with entrapment neuropathy than the inflammatory arthritis itself. MCP joint, the important arthropathy with MCP joint involvement is rheumatoid arthritis, and that is the commonest. Other rare conditions are pseudogout and hemochromatosis. Sorry. Then we have PIP involvement, which is usually seen in osteoarthritis, rheumatoid arthritis, SLE, psoriatic, etc. Then distal interphalangeal joint involvement. DIP is never involved in rheumatoid arthritis. So there are certain conditions like psoriatic arthritis. When patients come to us with DIP joint involvement, we have to at least look at two things, their skin and lungs. So obviously we have to keep in mind two conditions, two important conditions, which are psoriatic arthropathy, psoriatic arthritis and sarcoidosis. Then there is a little rare type which is called as multicentric reticulohistiocytosis, and of course osteoarthritis, which is a type of degenerative arthritis or arthropathy. There are certain patients who may have erosive osteoarthritis. I'm not going to get into details, but remember, OA can affect any joint except MCP, and rheumatoid arthritis can affect all the joints except DIP. So this is about upper limb. So we have patients coming to us with predominant lower limb arthritis. These are usually the group of spondyloarthropathies, the reactive arthritis or inflammatory bowel disease related arthritis or psoriatic arthritis. Then sarcoidosis sometimes can have, or most of the times can have, ankle arthritis, and otherwise they would not have any symptoms. They may just come with ankle arthritis. So at this time we have to do their chest x-ray, and they could be having asymptomatic hiral lymphadenopathy, and of course osteoarthritis, as I said earlier. So intermittent arthritis, as the name suggests, the arthritis comes and goes. So the important types are palindromic rheumatism, then gout, reactive arthritis and pseudogout. Palindromic rheumatism could progress to any of the rheumatological conditions like rheumatoid arthritis, SLE, spondyloarthropathy, etc., depending on the pattern of the joint involvement. The most painful condition amongst them is gout. Obviously, we all have seen gout in our clinical practice. Gout patients usually come with first MTP or knee involvement or sometimes ankle involvement, and the pain is excruciating. It is intermittent, comes once or twice or thrice in a year, and when it comes, they obviously get a lot of disability, and they give the typical history that whenever they take any particular NSAID, the pain just goes off. And if they have certain comorbidities like alcohol intake or some malignancies, or they are elderly, or they are on some medications like diuretics, etc., their uric acids could be elevated. So we have to know gout. Reactive arthritis, as I said, reactive arthritis, usually the fever precedes reactive arthritis, and sometimes you can have lower limb intermittent arthritis in reactive arthritis. Pseudo gout goes along with gout. Migratory arthritis, I think it used to be very favorite Viva question in our MBBS and MD. As the name suggests, migratory or fleeting, the one joint get involved, and after that the second joint gets involved. And when the second joint gets involved, the first joint involvement just vanishes. And few examples are rheumatic fever, or this is the most important example. Then there are certain rare varieties like sarcoidosis, Whipple's, endocarditis, SLE, etc. Amongst them, endocarditis and rheumatic fever have predominant heart involvement. So whenever patients come to us with migratory arthritis and fever with some shortness of breath, we have to do cardiac examination in detail. So after this pattern of joint involvement, we have to know about the aggravating and relieving factors. We have to know whether patient has excessive morning stiffness, which is usually more than 30 minutes. So which are the aggravating or relieving factors? The usually inflammatory joint conditions, they get aggravated with rest because of the hampered lymphatic drainage or the accumulation of the inflammatory fluid. They feel better with activity. They feel better with NSAIDs and steroids. The morning stiffness is usually more than 30 minutes, and they may have night pains, or the spondyloarthropathy patients will give you typical history that they will have alternate buttock pain whenever they have difficulty, they have so much back pain that they have to turn the positions at night. So this usually happens in the later part of the night. So this was about the skeletal involvement, appendicular skeletal involvement. Now coming to axial involvement, the important obviously arthropathies, ankylosing spondylitis or undifferentiated spondyloarthropathy. The second common type is psoriatic arthropathy, then reactive arthritis, enteropathic arthritis, which are usually associated with the Crohn's disease or ulcerative chloritis. In the areas where unpasteurized milk is consumed, we get to see brucella arthritis. Usually it is spondylitis of sacro, or there is a lot of sacroiliac involvement. It's an important differential for pyroxia of unknown origin. Rheumatoid arthritis. In rheumatoid arthritis, the axial involvement is very rare, but when patients have, they usually have cervical involvement, and when patients have it, it's sinister and it needs urgent attention. So obviously, sometimes patients will give you history of associated swelling. They will, the females or even males usually tell you that their rings get tight, or they see the visible swelling on their joints. So this basically rules out non-inflammatory cause. The visible swelling usually rules out fibromyalgia. Fibromyalgia patients or chronic pain syndrome patients will have definitely complaints of swelling, but that may not be visible. But whenever you see swelling, or if even if they have photographic presentation of swelling, it usually rules out non-inflammatory cause. I think drug history is important, and in our busy clinic or in busy practice, we tend to forget to ask these questions. So myalgia or myopathy, they are quite common with glucocorticoids, hydroxychloroquine, statins. Statin is very important. Then the tendon rupture or tendinitis, the notorious drugs are quinolones, etc. Diuretics, Lasix is loop diuretics. They can lead to hyperuricemia and gout. Then we all have treated a lot of TB patients, and we must have seen that pyrazinamide is notorious to cause hyperuricemia. Of course, alcohol, aspirin, these all can lead to hyperuricemia and can lead to gout. Steroids, alcohol bisphosphonate, they can lead to avascular necrosis of bone. Then steroids, phenytoin, heparin, etc. can lead to osteopenia or osteoporosis. Then there are certain drugs, there are many case reports related to pentazocine leading to skin fibrosis, which leads to scleroderma-like conditions. Then allopurinol, cocaine, TNF inhibitors, propylthiouracil, usually which is used in pregnancy for hypothyroidism. Montelukast, these are notorious to cause vasculitis. Montelukast especially is very much notorious to cause eosinophilic granulomatosis with polyangiitis. Then there are certain drugs. I think we all would have these MCQs, the SHIP, or the sulfa drugs or isoniazid, hydrolysine, ACE inhibitors, phenytoin, carbamazepine, they can lead to drug-induced lupus. They may have arthritis, photosensitivity, some cytopenias, and antihistone will be positive in them. So these are the certain drugs which can lead to rheumatological conditions. In constitutional symptoms, I think fever and rash are very important because they are visible, they are recordable, and they are usually told by patients. So the fever, rash, and arthritis, the triad usually seen in adult onset Still's disease. Patients will have lymphadenopathy or the proliferation of reticuloendothelial system in the form of, as I said, lymphadenopathy, then hepatosplenomegaly. SLE and dermatomyositis patients, 50 to 60% patients will definitely have fever before the onset of the disease. Then there are certain arthritis, infective arthritis like staph, streptococcus, Lyme's disease will have fever along with rashes. The triple H or hepatitis B, Hep C, HIV, Epstein-Barr, parvovirus, rubella, chikungunya. Chikungunya we all have seen a lot. These are all notorious to lead to fever, rash, and arthritis triads, and serum sickness reaction, of course. So these are the famous examples of fever, rash, and arthritis triad. Okay, so when you have preceding diarrhea or IV drug use, we have to think about these conditions: reactive arthritis, bacterial endocarditis, very much notorious. The IV drug abuse is very much notorious to cause staphylococcus bacterial endocarditis and septic emboli in lung. Then we can have septic arthritis, enteropathic arthritis, because they can have loose stools preceding. Enteropathic arthritis related to Crohn's or the ulcerative colitis. Coming to extra-articular manifestations, mucocutaneous involvement, I think skin and arthritis is very important. So the parvovirus, which we don't see so oftenly, but we have to remember this differential. Patients will have facial exanthema. The SLE rash, of course, we all know about it. It is typical photosensitive malar rash, which spares nasolabial fold. Then there is discoid rash, which is little hyperpigmented rash. Then dermatomyositis will have its typical rashes. I have pictures later like Gotton's papules, heliotrope rashes. Then psoriatic arthritis will have obviously the silver scaly psoriatic plaques. Behçet's SLE Crohn's disease will have oral and genital ulcers. Behçet's is notorious to cause genital ulcers, and these ulcers are usually, the oral ulcers are usually painless, so they often go unnoticed. SLE and Behçet's both. Uh, Erythema nodosum is quite common in sarcoidosis, enteropathic arthritis, post-streptococcal reactive arthritis. Erythema nodosum is a type of paniculitis, which is an inflammatory fat necrosis, usually seen on the shin of the tibia. The skin involvement is usually there. Then APLA and polyarthritis nodosa will have typical lacy rash, which is known as livedo reticularis. The non-blanching vasculitic rashes usually seen in HSP, which is hemorrhagic purpura, which is a common disease in children, ANCA-associated vasculitis and cryoglobulinemia. The keratoderma blennorrhegica and sarcinate balanitis is usually seen in reactive arthritis. Then, of course, skin thickening or skin hyperpigmentation we see a lot in scleroderma and Poems syndrome. So this is about the pictorial presentation. So we can see arthritis with erythema nodosum, post-streptococcal arthritis. These usually come in crops, and they have a lot of erythema surrounding it, and they are usually tender. So the examples are sarcoidosis, post-streptococcal arthritis, SLE, enteropathic arthritis. So of course, along with joints, we have to do the skin examination in detail. We have to look at their chest x-rays to see hilar lymphadenopathy for sarcoidosis. We have to know whether patient has any photosensitive rash. We have to look at their immunological or other blood reports to see whether they have SLE. Of course, we have to ask about their gut history to know whether it is enteropathic arthritis. So this is a typical picture of erythema nodosum. These are the rashes associated with reactive arthritis. This is sarcinate balanitis, and this is keratoderma blennorrhegica. These are psoriatic plaques, silver scaly psoriatic plaques. These are non-blanching. Obviously, I cannot tell you from the picture, but just because I have obtained with consent from one of my patients, this is non-blanching the vasculitic rash. So these are the typical oral ulcers on the hard palate in patients with SLE, Crohn's disease, and Behçet's disease. These are the rashes associated with dermatomyositis. So these are Gotton's papules, macules, usually typically on the MCP, PIPs, and DIPs of the hands. And this is typical heliotrope, the violet rash around the eyelids. So this is this associated with muscle weakness and arthritis is a typical feature of dermatomyositis. Ocular involvement is very important because eye is very important organ, and sometimes patients come to us with they usually go to obviously ophthalmologists. So ophthalmologists refer to us because they may not find a proper cause, or there could be some systemic involvement, or there could be some backache or arthritis. So usually with spondyloarthropathy, sarcoidosis, and with granulomatosis polyangiitis, you get uveitis. Then conjunctivitis is also associated with lot many rheumatological conditions. Scleritis, which is little sinister form of the eye involvement in arthritis, usually seen in rheumatoid arthritis, small vessel vasculitis like ANCA vasculitis, then relapsing polychondritis, and it needs urgent attention. Then cystoid bodies, these are rarely seen in SLE, and ischemic optic neuritis usually seen in giant cell arthritis or GPA. Ischemic optic neuritis is a very bad condition. Usually, if it is not treated urgently, patients may lose their eyes. Giant cell arthritis we don't see much common in India. It is usually seen in Western countries. But yes, we have patients with granulomatosis with polyangiitis or Wegener granulomatosis presenting to us with ischemic optic neuritis. So this is a typical picture of angry red eyes, the patient of RA with scleritis. Systemic symptoms again are very important. We have to know about cough, hemoptysis. Patients with ILD or some cavitatory lung diseases like in GPA or RA-ILD or scleroderma ILD or any pneumonia associated with these illnesses may have a cough with hemoptysis. They may have weight loss because of a lot of cytokine storm or inflammation. Of course, because of the same thing, a lot of TNF secretion, they may have appetite loss. They can have shortness of breath. The reasons could be varying. Hearing loss, otitis, epistaxis, scleritis, uveitis, sicca, these are usually associated with CTDs and vasculitis. Tingling and numbness when associated neuropathies, bloody diarrhea, as I said in IBD or any vasculitis, muscle weaknesses usually seen with inflammatory myositis involvement, and parotid enlargement usually seen in patients with arthritis with patients who take alcohol, or patients with Sjogren syndrome, they have parotid enlargement. So the important differential of parotid enlargement is mumps, but we don't see mumps so frequently on our OPD. Usually they are referred by ENT people. Other history, of course, they will have a lot of fatigue, altered sleep pattern, irritability, forgetfulness, headaches. They could have history of blood transfusion or many surgeries underdone, or any procedure done like CAG or surgery, because these procedure can lead to arthritis or the precipitation of the underlying autoimmune disorder. And the first three symptoms or the first three features are usually seen with patients with fibromyalgia. They may not have inflammatory arthritis, but they will have these things. They could be sent to rheumatologists because of all these symptoms along with arthralgias. So of course, at the end of the history, at least for me, the 70% diagnosis should be clear. For the expert people, it is sometimes 80 to 90% of the diagnosis. So at the end of the history, we basically have to know whether the joint involvement is acute or chronic, more than or equal, more than or equal to, or less than 6 weeks, whether it is inflammatory or non-inflammatory, then whether patient has single joint involvement, 2 to 3 joints involvement, which is oligoarthritis, or more than or equal to 4 joints involvement, whether patient has axial skeletal involvement like backache or the thoracic or lumbar vertebrae involvement, whether patient has extra-articular manifestations which include constitutional symptoms to all other systemic features. whether patient has other system involvement, even eye, ear, etc. So how do I examine? The examination should be done bedside initially at least. Then after that, you should look for the gait. So in RA, usually we look at 28 joint counts. In the famous scoring system is DAS 28, which is used for rheumatoid arthritis. So this is just a silhouette or skeleton which shows all the joints. So the joints involved can be marked. So I think all our practice, or the everybody, all practicing rheumatologists will have on their prescription pad. So general examination, we have to first see how, as soon as the patient comes, we have to see, look at their gait, or we have to see how, whether they have difficulty in sitting on the chair. We have to look at their general appearance, whether they appear cachexic, whether they have fever, whether they have shortness of breath, etc. We can notice quickly their body proportions. Then of course, when they lie down, we can see, or when we are doing a particular joint involvement, we have to look at the asymmetry between the two sides. We have to look at the swelling. We have to look at the deformities or any atrophy of any other limbs, then erythema or any skin rash. Then range of motion in active, when we do it, we have to see the range of the motion. We have to see the kind of pain patient has. We have to see or listen to the crepitus or popping, or we have to watch for the abnormal movements. Passive, of course, sorry, active when the patient does, and the same when we ourselves are doing a passive range of movements. Palpation, when we palpate, we have to know the anatomy of the structure. We have to see for swelling, warmth, and we have to look at each area for pain evaluation. Okay, so this is about the examination. As I said, rheumatologists are first and foremost internists. If any students are attending, you have to know that the examination, general physical examination, and the systemic examination is very important. So I told you extensively about skin involvement, ophthalmic involvement, nasal bridge, whether patient has any epistaxis or collapsed nasal bridge. Usually it is seen in GP or Hansen's. Then whether patient has any deformity of the ear cartilage, or whether patient has any discharge, any nail involvement, usually which happens in psoriasis, any digital infarcts or splinter hemorrhages. You get to see these things in scleroderma or infective endocarditis, any lymph node involvement. The most important thing which I have not written here is BP. I think our patients coming to us with hypertension, we have to pay attention to that. Sometimes large vessel vasculitis can come to you with just constitutional symptoms and hypertension. Then neurological examination is very important for a rheumatologist. We have to look at muscle strength, straight leg rising test. Then we have to look at reflexes. The things in red, they need urgent attention. Any arthritis with mononeuritis, multiplex or polyneuropathy need an urgent attention. Then we have to look at ascites, hepatosplenomegaly, because these can be there in underlying SLE. In we see ankylosing spondylitis, we see reduced chest wall expansion. Then we can have crepitations on respiratory examination when patient has interstitial lung disease in rheumatoid arthritis or scleroderma or SLE, etc. Patient can have pleurisy, they can have pain in deep inspiration, they can have decreased breath sounds when patients have pleural effusion. CVS examination is very important. Any of these are present, then they need urgent attention. Takayasu arthritis patients will have ascending aortitis or AR murmur. They may have conduction abnormalities. The new onset murmur associated with fever and arthritis, acute arthritis, usually tell us that patient may have underlying bacterial endocarditis, or some CTDs can have connective tissue diseases, can have myocarditis, and then pericardial effusion. Sometimes if it is unattended, can lead to cardiac tamponade, which needs urgent attention. So at least quick general physical examination and systemic examination is important. Then of course other systems which we usually forget to see, or which we may not pay a lot of attention, is usually nail, onycholysis, clubbing, pitting. These are seen in inflammatory bowel diseases, Whipple's disease or psoriatic arthritis. As I said earlier, parotid enlargement is seen in Sjogren's disease. large tongue, macroglasses, seen it with amyloidosis. The tophi, these are seen very nicely in gout patients. These are usually the crystal deposition which can have calcifications. Telangiectasias, these are just the dilated blood vessels. These could be present on the face, and usually these are seen in scleroderma. Dactylitis, these are the sausage fingers, or this is the type of arthritis enthesitis pattern. So usually these are seen in spondyloarthropathy. Of course, I know it in BCOPD it is not possible to look at all these structures, but at least we can try. If patients are smart enough and if they can tell you that I have problems, such and such problems, we can pay attention, we can have focused attention. So this is a typical picture of dactylitis. We can see it is the sausage fingers of hands and feet. These are usually seen in spondyloarthropathy groups. So yes, at the end of history and clinical examination, 90% diagnosis is made, and rest 10% or 10%, the investigations are only supportive to us. That's why sometimes it's been complained that rheumatologists take a lot of time to see the patients. But of course, when we have to look at all the systems and we have to make the diagnosis, 90% of the diagnosis from the history and clinical examination, we have to be sure. And investigation just they add to 10% of our evaluation part. Investigations, the sky is the limit, but it's better to order minimum, because all our immunological investigations could be false positive or false negative in any given patients. So we have to be very focused when we order. So I think it is for the physicians or orthopedicians or any other doctors who are seeing this. Whenever you are referring patients to us, if possible, please do basic investigations. So at least if we have, I'm clinically sure whether patient has rheumatoid arthritis or spondyloarthropathy or SLE, I can start immunosuppressive medications then and then, because I have liver function test and renal function test. So I don't have to think about about the toxicity of the drug later. So the basic investigations include CBC, ESR or CRP. You can order one of these. Then LFTs, liver function test, renal function test, hepatitis panel if you are if you feel. Otherwise it's not mandatory, but I think in India it's better to do it. Thyroid is very important, especially in females. Random blood sugar, it is important because most of our patients are on steroids. And chest x-ray, I am keep coming to chest x-ray, especially in COVID we all have learned importance of chest x-ray. This is important. Important investigation which I have not written here is urine routine. If possible, please do urine routine also. So these are the arthritis specific investigations. When I'm sure or when I think patient could be having rheumatoid arthritis, of course, rheumatoid factor and anti-CCP. ANA is usually done for patients who are probably suffering from systematic lupus erythematosus or SLE or other CTDs like scleroderma or MCTD, etc. HLA-B27, as we all know, is usually done for spondyloarthropathies. ENA profile is a further investigation of ANA. These are extractable nuclear antigens, and these are there are many antibodies which are present in antigens present in the cell. So these are antibodies to the particular antigens in the cell. ANA usually is a screening test. If ANA is positive, then ENA is usually advisable. However, so there are certain antibodies which could be present even if ANA is negative. Synovial fluid analysis, just if we think it could be septic arthritis, or we have to look at we have to do crystal examination. Musculoskeletal ultrasound, I think we are all stay I think we have been learning about MSK USG. It is very important, it can pick up the disease in the early stages. Then MRI of spondyloarthropathy, for MRIs of sacroiliac joints, hand joints. MRI of SI joints is particularly important for spondyloarthropathies. Synovial fluid indications, as I said, when patient comes to us with acute monoarthritis or with some other features like fever, etc., to know the etiology, it's always better to do the synovial fluid examination. It could be sometimes therapeutic. Patients feel better after you take out, especially when it is septic arthritis. Of course, then for crystal arthritis, for even academic purposes, I think sometimes we do synovial fluid examination. I won't get into detail, but usually there is a lot of leukocytosis or neutrophils in bacterial arthritis, and in crystal arthritis, the appearance is usually turbid. Okay, this is, I think, one of the last slides. So there are a few arthritis which accompany systemic diseases. So the arthritis, or sometimes arthritis can have the constitutional symptoms, but these are the primary diseases, and they can have arthritis or joint involvement, like carcinomatous polyarthritis, amyloidosis, hemochromatosis, sickle cell anemia. These are little rare conditions. The more commoner conditions are hypo or hyperparathyroidism, hyper or hypothyroidism, diabetes mellitus, very important. I think we all have seen diabetic karyoarthropathy or limited joint involvement, adrenal gland insufficiency. These patients may have joint involvement or some rheumatological illnesses underlying, and paraneoplastic etiology. If elderly patients come to you with pitting edema and arthritis, we have to think about the underlying malignancy. So to conclude, I think history is very important. History should be sought in detail. Examination should include all the system and not just the joint. A proper history and examination can help reduce the cost of investigations to the patients. And I agree with Nalawade sir that I think what he said, that when to start DMARD or starting DMARDs early is important. But again, what I feel is we have to avoid starting DMARD till I'm sure about the disease, because once we start the DMARDs, we really cannot stop them. They have to be continued for long term. But of course, as he said, is very correct. The DMARD should be start as soon as you are sure about the diagnosis, and stepwise approach is always beneficial. I hope I could cover all the points, and if you have any questions, please ask me. Thank you.
Yeah. Thank you, Dr. Gayatri, for
Thank you, sir.
lucidly presenting such a vast topic. Okay, so basically what we can gather from Dr. Gayatri's talk is that all polyarthritis is not rheumatoid arthritis. We have seen so many differentials that we need to consider when patient comes with multiple joint pains. And more importantly, history taking, pattern recognition, and clinical examination is the most important thing in patients with multiple joint pains. And again, what we miss many times in our clinical practice is the medication history, and that again forms very important thing what she has said. Now we have say another 10 minutes for few questions which I will ask the panelists. We also have Dr. Dheeraj Attardi who has joined us now, and he is a young orthopedician consultant in Sancheti Hospital. Okay, so I'll start few of the questions. I'll start first with Dr. Nilesh Patil. He is a rheumatologist with Sancheti Institute, and my question to you, Nilesh, is in current scenario when we are along with COVID, we are also having a viral polyarthritis, that is chikungunya arthritis. So for primary care physicians or orthopedicians who usually see these patients for the first time, what advice or what will be your guidance to assess whether this is viral polyarthritis or maybe inflammatory arthritis? Can you give us some tips that will help in clinical exam?
Generally, yeah. Thank you, sir. First of all, thank you, Gayatri, for such an elaborative and lucid presentation. So coming to the question, so when a patient with this viral polyarthritis comes, generally the presentation is like rheumatoid arthritis. The patient comes with polyarthritis, and sometimes the patient has polyarthralgia. There is no obvious synovitis clinically. So there is a distinction. So that is a distinction. In rheumatoid, there is obvious synovitis all the time, but sometimes again, a viral polyarthritis can present with some noticeable synovitis. And so for this patient, we should always ask history for the fever. So generally, these patients, they do give history of fever for 1 or 2 days or maybe 3-4 days. And sometimes these patients, they always have rash. So most of the time, these are viral arthritis, and then the treatment goes with just simple painkillers or NSAIDs. And if not, then sometimes hydroxychloroquine we can add. And if so, this 20% of this viral arthritis, they can go into chronic phase. So their DMARDs are required. So most of these patients, they have their own course. Next 3 to 4 months, within the period of 3 to 4 months, they recover. So for the time being, we should give NSAIDs. And if the patients are not getting better with NSAIDs, then small dose of steroids also help.
Okay, thank you,
The
Nilesh.
major difference is clinically seen. Yeah. Thank you. Sir.
So what Dr. Nilesh has told us that asking history of fever, especially if patient is presenting with acute polyarthritis, is very important. Acute means joint pains which are less than 6 weeks. Okay. Now moving on to Dr. Nilesh. So I am hurrying a bit because we are short of time. Uh, Dr. Nilesh, we would like to know the orthopedic perspective. So, in your practice, I'm Dr. Nilesh Jagtap. I'm asking. Okay, so Dr. Nilesh Jagtap,
Yeah,
are you
yeah.
okay? Because we have two Nilesh, so probably. So, my question to you is: in your practice as an orthopedician, how many percentage of patients with inflammatory joint pains do you see? And what some patients might have polyarticular generalized osteoarthritis. And what is usually your approach towards these patients?
Uh, See, very few patients I saw regarding polyarthritis. My approach is I do the basic clinical examination, basic investigation. If I confirm it looks like rheumatoid arthritis or any other seronegative arthritis, I directly refer to rheumatologist.
Okay.
I never
So
treat the patient.
any basic tip that you can uh, label the patient as osteoarthritis rather than inflammatory arthritis? Any clinical tip for our primary care physicians?
Primary osteoarthritis.
Yeah, primary osteoarthritis. So
Okay.
early, apart from pain, probably early disease will not have many signs, but in inflammatory arthritis, we tend to have a lot of stiffness. So do you feel that osteoarthritis patients also have stiffness, or it is not that prominent in osteoarthritis?
Yeah, so primary osteoarthritis like osteoarthritis of the spine or knee. So they have the pain, so we treat them analgesic, anti-inflammatory, then physiotherapy, and short wave diathermy like things, and do the basic X-ray to confirm the stage of the osteoarthritis, and according to that we treat the patient.
So Dr. Nilesh tells us that X-ray is very important for confirming diagnosis of osteoarthritis, and
Yeah.
we can definitely differentiate it from generalized osteoarthritis versus rheumatoid based on X-rays. So coming to Dr. Gayatri, so what are basic X-ray findings wherein you will be able to differentiate rheumatoid arthritis versus osteoarthritis in a patient complaining of hand pains?
Okay, so first of all, the 17 to 18% of the rheumatoid arthritis will have erosions at the start of the disease. So before answering your question, I would like to say that even if the patient comes to us for the first time, I would like to order X-rays of both hands and feet, if possible at feet also, but at least X-ray both hands. AP view is what I prefer. In rheumatoid arthritis, I can see early erosion, the joint space narrowing. Usually it is PIP and MCP and wrist involvement. Whereas in osteoarthritis, there would not be many erosions unless it is inflammatory osteoarthritis. And if at all erosions are present in osteoarthritis, these could be secondary to underlying systemic arthritis like RA. But primary osteoarthritis can have erosions or involvement in distal interphalangeal joints especially. So these are the basic things I would like to see in hand joints. Otherwise, the knee X-rays will not help me much for rheumatoid arthritis. But as Jagtap sir said, these are very important for confirmation or to see the progression of osteoarthritis.
On knee X-ray, you can judge that it is a primary osteoarthritis or rheumatoid osteoarthritis. Like in
Sir,
advanced rheumatoid,
usually.
the joints, X-ray, the joint is subluxated. In primary osteoarthritis, there is a lot of sclerosis. You can see the osteophytes. So clinic on X-ray, you can confirm that it's a primary or any other osteoarthritis.
So usually patients with osteoarthritis will have more of sclerosis
Yeah,
and or what we call as hibernation and maybe some bone production, osteophytosis and asymmetric joint space narrowing. So usually rheumatoid has symmetric joint space narrowing.
right.
Okay. So this is a very cheap investigation which can help primary care physicians and orthopedicians sometimes to differentiate this inflammatory versus degenerative arthritis. Dr. Dheeraj, I have a question for you. See,
Yes,
you
sir.
probably practice more of a uh, trauma orthopedics and all,
Yes.
but I'm going to ask you whether uh, say like what are the indications of arthroscopy in patients who present with joint swelling. So when would you recommend that patient should undergo arthroscopy for a patient who is presenting with arthritis?
Yes, sir. At early to moderate severity of disease, when there is synovitis and patient's pain is not getting relieved by regular analgesics, and if any tubercular or any other pathologies coincides with because of immunosuppression, then synoectomy can be done with the arthroscopy. As well as in the osteoarthritis, age-related osteoarthritis, if it is at early stages, then you can always do a arthroscopy and primary debridement of the joint. That always helps.
Okay, thank you, Dr. Dheeraj. So Dr. Dheeraj tells us, especially if it is monoarthritis, which is not responding,
Yes.
we are suspecting of tuberculosis, has some systemic symptoms, arthroscopy might help, or uh, or even with patients with polyarthritis, if all joints are responding to treatment except one odd joint which is not getting, one odd knee joint which is not responding, probably arthroscopy might help. Okay, I think we just have 3 minutes. So one last question to Dr. Nilesh Patil. And uh, so for our audience, say, who probably are more of primary care physicians, so what one question that you would like them to ask their patients when patient complains of, I have this joint is paining, that joint is paining, this joint is paining? Okay, so you want me to repeat the question?
Yes.
So for the
I'm
primary
not
care
able to hear.
huh? For the
So,
primary care
can you,
physician, huh?
yes, yes.
So the for primary care physicians, when they are sitting in their clinic and
Mm.
patient comes to them saying that my hand joints are paining, my leg joints are paining, my knees are paining.
Yes.
So what is $1 million question that you would want your primary care physicians to ask the patient?
Yeah. So my question is my one suggestion would be just try to find out whether it is an inflammatory arthritis or non-inflammatory arthritis
Yeah.
just by asking history. So history is very important. So first, history should be always whether the patient has early morning stiffness in the joints, and second, if the patient has any associated swelling. So these two questions can definitely differentiate.
Yeah, thank you. So, so always one should inquire whether patient presenting with multiple joint pains has early morning stiffness, and that really narrows down the diagnosis. Since we are out of time, I would like to thank all the panelists for coming here and enlightening and guiding us all. And uh, I think uh, I I will have to. So Rahul, uh, okay, I I will present the vote of thanks, and it's my privilege to propose vote of thanks today for this session. I, on behalf of Sancheti Hospital and Rheumatology TV, extend my very hearty vote of thanks to Dr. Gayatri for giving a talk today. And a big thanks to all panelists, Dr. Nilesh Patil, Dr. Nilesh Jagtap, Dr. Dheeraj, for coming here today and sharing your views. Uh, in fact, I would like to extend a thank to our team behind the Rheumatology TV, Dr. Ashok Sham. He has been very instrumental in initiating, in taking this initiative. Dr. Rahul, who is always Rahul Chobe. In fact, he is now one of us, so he's become a doctor, maybe PhD in all this. So I would like to thank him from bottom of our heart, and I wish to express my gratitude to Dr. Parag Sancheti for his encouragement and motivation to start this Rheumatology TV and use this platform to share information. And last but not the least, I would like to thank all the audience for being here. A very big thank you to all of you again, and have a very nice evening. Thank you.
Yes,
Thank
sir.
you, sir. Thank you.
Thank you.
Thank you.
So over to you, Rahul.
Thank you. Bye.
Okay, thank you. Thank you.
Yes, sir.
Thank you. चलो बाय धीरज बाय गायत्री
येस सर हा हो येतोय मी बंद हो बंदच करतोय